All right. Hello, everyone, and welcome to today's seminar titled Advancing the Role of Death Investigations for Surveillance, which is the seventh of the Surveillance Advances seminar series, co-hosted by the Public Health Agency of Canada and National Collaborating Centre for Infectious Diseases, or NCCID. My name is Signe Berger, and I am a project manager at NCCID. I will be your moderator today, along with Louis Wong, who is an acting manager in the Data Surveillance and Foresight branch of the Public Health Agency of Canada, and Stefan Hardy, our bilingual moderator for the Q&A session, who is a communications officer at the National Collaborating Centre for Indigenous Health. NCCID is funded by the Public Health Agency of Canada to provide knowledge and evidence for use in public health planning, programs, and policies related to infectious diseases. We are incredibly pleased to be co-hosting this series with the agency. I would like to acknowledge that NCCID is hosted by the University of Manitoba on the original lands of the Anishinaabe, Cree, Oji-Cree, Dakota, and Dene peoples, and on the homeland of the Métis Nation. At NCCID, we strive to honor the lands and their original caretakers in our work. We acknowledge that we are on Treaty 1 land. We recognize that this and other treaties have been implemented as part of the process of colonization, intended to benefit some while harming others. We are committed to working with our partners towards reconciliation. Now, before we dive into today's seminar, there are a few housekeeping items that I would like to mention. A recording of this seminar and presentation slides will be available shortly after the seminar on the NCCID website, nccid.ca, under webcasts. The chat box for participants has been disabled for this session. The hosts will use the chat box to communicate additional information with participants. If you have technical problems with Zoom during the seminar, please email us at nccid@umanitoba.ca. And please send us topic-related questions through the Q&A tab, and we'll try to address as many as possible in the discussion period after the presentation. You can also like any of the questions to push them up in priority. We would also like to note that Surveillance Advances is a Section 1 self-approved group learning activity as defined by the Maintenance of Certification Program, the Royal College of Physicians and Surgeons of Canada. The seminar series is also approved by the Council of Professional Experience for professional development hours for members of the Canadian Institute of Public Health Inspectors. If you require a letter of participation, please look out for the survey that will be shared after the seminar.
Great. Thank you so much, Signe, and good morning or good afternoon. Thank you, Signe, for going over some key important housekeeping items. Welcome, everyone, and thank you for joining us today. Bienvenue à tous et merci d'être parmi nous aujourd'hui. While today's seminar will be delivered in English, we welcome everyone to pose their questions in their official language of choice, in either English or in French. I would like to begin by acknowledging that the land on which I gather is the traditional territories of the Wendat, the Anishinaabe, the Haudenosaunee, the Métis, and the Mississaugas of the Credit First Nations. Today, we will have participants and presenters joining us from coast to coast to coast. The land in which they and you join us from represent the lived experiences of many Indigenous people, all of which have their own unique health stories. To public health professionals, surveillance sounds similar to epidemiology, which is about understanding the distribution and patterns of the determinants of health and diseases in populations. But for others, surveillance may carry negative connotations about security, privacy, and control. For this seminar series, we would like to note that we use the word surveillance to refer to the assessment of and response to public health threats as a core function of our public health systems. And lastly, the seminar series is not just about the speakers or the organizers, it's about you, the audience, and your active participation, questions, and perspectives are vital to the success of this series. We encourage you to engage in discussion, ask questions, and share your thoughts and foster collaborations that can lead to improvements in public health surveillance. Back to you, Signe.
Great, thanks so much. So with excitement, I would like to introduce and welcome our speakers for today's seminar. Derek Schulten completed a Master of Science in Epidemiology and Biostatistics at Western University in 2002, and then joined the Canadian Field Epidemiology Program at the Public Health Agency of Canada as part of the 2003 to 2005 cohort. Since then, Derek has continued to work at PFAC as an epidemiologist in the areas of national tuberculosis surveillance and case response, notifiable disease surveillance, and supporting various corporate surveillance initiatives. In 2017, Derek helped to establish national surveillance of apparent opioid toxicity deaths with provincial and territorial public health and death investigation partners. This led to his current position, working with provincial and territorial chief coroners and chief medical examiners and Statistics Canada to facilitate more timely and comparable death investigation findings for surveillance to inform strategies to reduce preventable deaths. Emily Schleihauf is an epidemiologist who has worked in the Canadian Public Health Service of the Public Health Agency of Canada since 2008. She's been placed in various capacity building roles in Nova Scotia and has provided surge support for various outbreak responses over her years with FAC. Currently, Emily is placed with the Nova Scotia Medical Examiner Service, building and expanding public health surveillance through analysis and knowledge translation of information and data collected through death investigations on topics ranging from drug toxicity to suicide to infant mortality. Dr. Christopher Murray is professor and chair of the Department of Health Metrics Sciences at the University of Washington and director of the Institute for Health Metrics and Evaluation. His career has focused on improving population health worldwide through better evidence. A physician and health economist, his work has led to the development of innovative methods to strengthen health measurement, analyze the performance of health systems, understand the drivers of health, and produce forecasts of the future state of health. He's led critical analyses during the COVID pandemic to understand its impact on health systems and the population as a whole, and the effectiveness of policy interventions to mitigate it. The White House, European Commission, many governments and organizations such as the WHO, Euro, PAHO, and Africa CDC used the IHME, or the Institute for Health Metrics and Evaluation, COVID-19 forecasts and policy scenarios as a trusted source of evidence. Dr. Murray also leads the Global Burden of Disease, or GBD, collaboration, a systematic effort to quantify the comparative magnitude of health loss due to diseases, injuries, and risk factors by age, sex, and geography over time. The GBD is now a network of over 11,000 scientists and decision makers from 162 countries who work together to generate annually updated estimates. He is an elected member of the National Academy of Medicine and the 2018 co-recipient of the John Dirks Canada Gairdner Global Health Award. Welcome, Derek, Emily, and Dr. Murray. We are happy to have you join us today, and we're so excited to learn about your experience and knowledge in death investigations and surveillance. We'd first like to invite Derek and Emily to share their work. The floor is yours.
Great, thank you very much, Signe. And it's a pleasure to be here today. Next slide, please. Emily and I, neither of us have a conflict of interest to declare. Next slide, please. Today, through our presentation, we hope that you'll learn about death investigation in Canada and how data from death investigation findings are collected at the national level. We hope you'll understand the origins of and focus areas of the chief coroners, chief medical examiners, and public health collaborative, and learn how death investigation findings can be used for surveillance activities that can inform strategies to reduce preventable deaths. Next slide, please. So in terms of a background, approximately 15 to 20% of all deaths are investigated by coroners and medical examiners. In Canada, medical legal death investigation services are a jurisdictional responsibility of provinces and territories, including the corresponding legislation for that service. Provinces and territories either have a coroner-based system or a medical examiner-based system. Coroners and medical examiners investigate deaths that are unexpected, unexplained, or that occur by violence. For example, homicides, including domestic homicides, suicides, substance-related toxicity deaths, and infant, child, or maternal deaths. Pan-Canadian public health surveillance seeks to use timely and comparable death investigation data to address evidence needs to inform prevention efforts. Death investigation data at the national level are collected in the Canadian Coroner and Medical Examiner database, known as CCMED, that's held by StatCan. And I'll refer to that more on the next slide. Next slide, please. So what is the Canadian Coroner and Medical Examiner database? Well, CCMED was established in 2008 at StatCan in collaboration with the 13 provincial territorial chief coroners and chief medical examiners, or CCMEs, and the Public Health Agency of Canada. It contains over 500,000 records from 12 jurisdictions that span years 2006 to 2023. Data files are submitted to Stat Canada from CCME offices and include information on demographics, the manner of the death, the cause of death, which is text-based, other health conditions, circumstances of the death, the place of the death or the event, and safety information, as well as, from some provinces and territories, a text-based narrative. And this represents just a portion of what's available in death investigation files at the provincial territorial level. Next slide, please. There are some system challenges and limitations that do result in a lack of availability and timely access to comparable national data in order to inform public health surveillance. And this leads to an inability to consistently identify, evaluate, and monitor mortality trends at the national level, which reduces the opportunity to inform intervention or prevention efforts. With respect to the death investigation system, although there are many more similarities than differences, there are various approaches to death investigation and data collection across provinces and territories. There's limited resources in CCCME offices for data management and surveillance activities. And with respect to case management systems, there are a variety of systems being used, some of which are paper-based and some of them which are not amenable to change. With respect to the CCMED, there is a lack of data comparability and completeness across PTs, and there's a lack of pan-Canadian coverage. For example, currently there is no data sharing agreement with Manitoba. And there is limited timeliness in that some provinces and territories only submit death investigation data after the investigation is closed, which can sometimes take months or up to 2 years. And there are delays with respect to accessing the data. For example, Public Health Agency of Canada can only access the CCMED data once it's been released by StatCan. And finally, it's not easily analyzed, where the cause and circumstance information in CCMED is mostly text-based and then lacks the discrete data elements to capture key circumstances information that can be used for surveillance. Next slide, please. So within this context, I'll go over the origins of the collaborative, the chief coroners, chief medical examiners, the collaborative. And really, I'm not going to go over through each of these steps in these timeline slides in detail, but essentially the collaboration between public health and death investigation systems stems from the development of a pan-Canadian public health surveillance system to monitor opioid-related toxicity deaths following the rapid increase in substance-related toxicity deaths observed in 2015 and 2016. This surveillance system relies on death investigation data that are sent to the Public Health Agency of Canada from all 13 provinces and provincial territorial chief coroner and chief medical examiner offices, given the challenges that are outlined in the previous slides to do with CCMED. The data are sent to FAC either directly from CCME offices or through the respective public health departments in that jurisdiction. The surveillance system was developed in collaboration with the Public Health Agency of Canada's traditional provincial territorial public health partners, as well initially with 2 chief coroners, the chief coroner from British Columbia and the chief coroner from Ontario. And as the system was incrementally expanded over time, so did the collaboration with more chief coroners and chief medical examiners as the data elements and the questions being asked of the data became more technically challenging, requiring more collaboration with chief coroners and chief medical examiners. Following this development, in early 2018, the National Forum of Chief Coroners and Chief Medical Examiners wrote to the Federal Ministers of Justice and Health to identify more broader opportunities to use death investigation data in their systems to inform public health prevention policies. And following this, a meeting was held between Dr. Heyer, the Chief Coroner of Ontario, and then Chair of the National Forum of Chief Coroners and Chief Medical Examiners, and Dr. Cham, the Chief Public Health Officer of Canada, to discuss the objectives, approaches, and resources that could support collaboration between death investigation system and public health. Next slide, please. Following this, a statement of purposes was established, including key focus areas and work plan priorities amongst chief coroners and chief medical examiners, FAC and StatCan, to inform collaboration and knowledge exchange. And then following a domestic and international scan looking at models of collaboration in other countries and parts of Canada on the use of death investigation data to inform policy, the collaborative was established as a pilot in September 2021. Next slide, please. That's it. So the collaborative is the collaboration amongst the provincial territorial CCMEs, the Public Health Agency of Canada with respect to a technical secretariat role, and StatCan, who holds CCMed. The collaborative supports a vision where Canada has timely information from death investigation that can be used to identify trends, inform policy, prevention measures, and to respond to emerging threats, all in the interest of reducing preventable deaths. As part of this vision, the collaborative is working toward more cohesive death reporting systems across the country, a centralized national database with common data element sets on priority causes of preventable deaths to enable timely access by provincial, territorial, and federal government departments, as well as researchers and media. As part of this vision, it envisions a death prevention policies and measures that have strong evidence base and are to create a more meaningful impact across multiple sectors, including health, justice, and public safety. Next slide, please. I should mention that the United States also has a similar initiative that's been developed through the Center for Disease Control and Prevention. In 2022, they set up the Collaborating Office for Medical Examiners and Coroners, which strives to foster more quality, consistency, and coordination amongst public health surveillance efforts and the medical death investigation community. And we've provided the link there for your own reference. Next slide. So through Budget 2022, the Public Health Agency of Canada received 3 years of funding to move beyond the pilot stage of the collaborative, including establishing a technical secretariat within FAC, which supports the technical development of what we call common approaches to death investigation and minimum data element sets. It also includes support for the augmentation of CCMed to receive the data elements developed through the collaborative and to improve the timely access to data for public health. And finally, this includes improving the capacity of CCME offices, which includes the placement of public health officers, which I'll describe on the next slide. So public health officers were included in the budget with respect to a capacity building component, and 6 public health officers have been placed. PHOs provide epidemiology, analytic, and data management capacity to their host CCCME office placement and support joint federal, provincial, and territorial priorities that are established under the collaborative. This new stream of public health officers is referred to as the Public Health Death Investigation Stream, and it was launched in 2022 of December, and has funding until March of 2025. The Public Health Death Investigation PHOs are coordinated through the Canadian Public Health Service, which is a public system capacity building service at the Public Health Agency of Canada, which recruits, hires, and places public health officers who are largely epidemiologists or public health nurses in host organizations across Canada to support joint FPT priorities. The Collaborative Secretariat provides public health officers in CCME offices with mentorship, technical support, and coordination with collaborative activities, and including knowledge exchange amongst PHOs. Next slide. So the collaborative has established several subgroups to work towards its vision. And that includes, as I mentioned, the development of data element sets on priority causes of death, as well as common approaches to death investigation that promote consistency and to facilitate more comparable data to inform prevention strategies and policies. The current priorities of the collaborative are substance-related toxicity deaths, suicide deaths, and to explore methods to capture information in death investigation on populations that are disproportionately affected due to existing health and societal inequities, including those with unstable housing, Indigenous populations, and members of the 2SLGTBQIA+ communities. and also on information on race and ethnicity. Next slide, please. We'll now switch gears a bit and provide you a couple of examples of surveillance activities that use death investigation data. Next slide. The first is one that I referred to earlier, and that is the pan-Canadian surveillance system that tracks apparent opioid and stimulant toxicity deaths. And I'm presenting these slides on behalf of my colleagues in the surveillance group that we work with. So in 2016, as mentioned, there was a special advisory committee set up through the Public Health Network which is a time-limited subgroup to advance the response of the federal government and the federal, provincial, territorial governments to the increase in substance-related toxicity deaths. And one of the first things they did was to set up what's called now the Substance-Related Mortality and Surveillance Task Group, which has a mandate to implement pan-Canadian data collection, collation, and synthesis, and information exchange in order to track the ongoing epidemic. Next slide, please. The task group collaborated, as I mentioned, with provincial, territorial public health colleagues, as well as chief coroners and chief medical examiners, to set up a surveillance system that was initiated in 2017. The stated surveillance objective of the system is to compile death investigation information from provinces and territorial chief coroners and chief medical examiners related to apparent opioid and stimulant toxicity deaths, their distribution by person, place, and time, manner of death, and the substances involved, and produce and disseminate descriptive summaries on a quarterly basis in order to address the stated objectives of the surveillance system, which are to describe the distribution of substance-related toxicity deaths across Canada on priority substances, to monitor challenges in the occurrence and distribution of those deaths, and to facilitate federal, provincial, territorial, and local government and health systems action. Next slide, please. As I mentioned, the system was developed incrementally, and please advance through this slide. It started with some very minimal information back in 2017. You can keep advancing through the circles. And so then it expanded incrementally to include information on the substances involved. And then it went into more information on the substances with respect to the origin of the opioids, such as whether they were pharmaceutical or non-pharmaceutical in nature. It then included other information, including adding the surveillance target of stimulant toxicity deaths. And then it added multivariable stratification, which included or allowed analysis by age, by sex, and sex by the type of opioid involved. Next slide, please. In addition to 29 quarterly data releases that are posted on the Health Infobase, the data releases have also informed many other products, including minister statements, joint statements of the co-chairs of the Special Advisory Committee, a federal action website on the response to the overdose crisis, modeling brief reports that are prepared by the Public Health Agency of Canada's Substance-Related Harms Division, and serves as context for other departmental work, including Health Canada's Drug Analysis Service. Next slide, please. I'll now pass the floor on to my colleague, Emily, who will describe some surveillance activities in the Nova Scotia Medical Examiner Service.
Thanks, Derek. So, as a public health officer placed with the Nova Scotia Medical Examiner Service, I've been able to support those quarterly data releases on opioid stimulant toxicity deaths, both through sitting on various subgroups as well as submitting the actual data for Nova Scotia's mortality situation. Next slide, please. Here you can see a stepwise representation of how Nova Scotia has operationally set up systematic public health surveillance activities. So you can see this is a series of kind of cleaning and coding steps, followed by reporting and iterative cleaning, coding, reporting, as we are all aware for surveillance activities. So because the data we use before formal ICC coding processes makes it a lot more flexible, but also a little bit more different to use. So case definitions that are decided upon at top, largely related to kind of syntax searches of cause of statements. Then, code is run and applied and tested, and case identification is tested for accuracy. Then, you can make your iterative review of the sensitivity and specificity of those definitions and assess the needs for additional indicators. New indicators can be created, and these can be related to contextual factors based on the case, the situation, time of death, other factors related to demographic or situational factors of the decedent. And this is done in continuous collaboration with this chief coroner, chief medical examiner, public health collaborative, to ensure that the province is working in a consistent way for comparable data nationally as possible. And then the information can be, oh, sorry, choppy. I'll go closer. The information can be incorporated into routine reporting. And then eventually, CCMed integration is the desire for the national picture as appropriate. Next slide, please. While we continue to collaborate here in Nova Scotia with various partners on various surveillance activities as well as internal monitoring, there are a number of surveillance products currently publicly reported with routine refreshes of this information. We have a data story on suicide mortality, and it describes trends over time and space, age group and sex. We have suicide methods as well as dimensions of deprivation as per the Canadian census. There are various tables and visualizations on drug toxicity mortality over and above what is reported nationally in the Public Health Agency of Canada reports. Soon there will be a report describing trends in all deaths investigated by the Nova Scotia Medical Examiner Service in the less than 25-year age group. This is in support of the work of the newly established Child Death Review Committee and is a unique use of the data from the Medical Examiner Service. It also will inform recommendations to prevent future deaths based on trends in these data. A data table and visualization will also be published soon, describing trends in motor vehicle driver deaths by the drugs detected. Next slide, please. There are three major benefits of using death investigation data we see in using this information in Nova Scotia surveillance. The first is timeliness. Early detection of threats and unusual patterns and clusters is possible if going right to the source of death investigation data. We have seen detection of increased toxicity deaths by certain drug types here through our monthly reporting. We've also been able to test for any association between suicide and mortality in the early days of the pandemic when the questions were very topical. Accuracy and specificity is also key. We know that in the early days of looking at drug toxicity mortality, methamphetamine deaths were grouped together in ICD coding and unable to be teased apart. That has since been changed, but when we go straight to the source, we can do this. Multiple levels of contextual information can also be added, such as the living situation of decedents, looking at social and structural determinants of health, looking at swimmability and boating or swimming or other activity at time of death, etc. We'll go to the next slide, please. I won't go into this slide, but there are some links here, and it was just to show you examples of outputs that are currently available from the Nova Scotia Medical Examiner Service. The left is a research article related to suicide and the ability to monitor in real time rather than to wait for years to answer questions on whether there are any associations between these types of mortality and the pandemic. The middle is just examples of some online reporting that also is very interactive, so you can change the drug types, etc. And the right side is the part of the data story. It is much longer, the suicide data story. It scrolls up and down. This is what it looks like. Next slide, please.
Oh, my apologies, sorry. Emily. Can we just have you maybe try adjusting your mic to see whether or not that resolves some of the choppiness? And apologies,
sure.
Participants. Oh,
no,
that's
my
better.
Apologies. Okay. Thank you. I'm just finishing up here too, so sorry for the choppiness. We wanted to mention the multiple stakeholders that can benefit from the information shared, including public health and health system partners, offices of addictions and mental health, justice and social services partners, also community-based organizations, as well as media and the public, who we believe in the democratization of the data for all. Release of this information through things such as open data platforms allows for data tables and visualizations, allows government to be proactively transparent and supporting research and others. We do have protocols designed to mitigate risks of individual attribute and community disclosures. Next slide, please. So what Jared and I had put together as key messages to take away from today is that the Chief Coroners and Chief Medical Examiners Public Health Collaborative is an innovative cross-sectoral initiative among federal, provincial, and territorial partners working to improve timeliness and comparability of death investigation data. We believe that findings from the death investigation data are an important source of information for public health surveillance and researchers to inform public health strategies to prevent deaths. Three key things, including the timeliness, specificity, and context of deaths, make better public health surveillance that can do better to inform prevention activities. And I'll end there. I apologize, I didn't realize that this would be so choppy.
Fabulous. Thank you, Emily and Derek, for your wonderful presentation. We now invite Dr. Murray to share his screen to present.
Great. I would like to use the GBD as an example. There we go. As an example of using mortality and cause of death data to try to understand what's happening in a country or a range of countries, and then talk a little bit about the direction that the GBD has taken towards subnational burden estimation and the most elaborate version of that, which is in the US, to look at subnational burden by county and race ethnicity. So for those who aren't familiar with the GBD has been running more than 30 years. There's a piece in Nature Medicine on the history of it, if you are interested, that came out a couple of years ago. But you can think of the GBD as a rules-based evidence synthesis exercise where we take all the available mortality, cause of death data, and disease incidence and prevalence and risk factor data to try to use a standard set of methods to characterize what are the main health problems in each community. Now, I want to, right at the outset, say that one of the unique attributes of the GBD, which doesn't have to do with the data, but has to do with the people conducting the GBD, is that it's a very large-scale collaborative enterprise. With now, we have surpassed, since this slide is made, the 12,000 mark of enrolled collaborators who have, read our study protocol, agreed to its terms, and participate in sort of all aspects of the GBD exercise. And in addition to those individuals who span research institutions and government and universities, we also have a number of direct government and or in regional or global institutions that we work with, ranging from Africa CDC to a number of ministries of health. If you're interested, you can see the data sources, such as the vital statistics that we use, the verbal autopsy surveys that we use, and everything else in an online data catalog called the Global Health Data Exchange. GBD 2021, which is the version that is now being currently published and fully released on May 16th, includes 317,000 different data sources, where the Canadian vital statistics would be one of those 317,000 sources for a year. So if we used multiple years, we would count that as multiple sources. But still, it's a very large effort at data synthesis. It also, if you are interested, you can look in an online tool and query the results from the GBD. For the 21 countries where we do subnational burden as part of the routine exercise, you can query those as well. And otherwise, you can explore the 204 countries that we include in the GBD exercise. Okay, on to how we use mortality data and cause of death data So we try going back actually to 1950. This slide is only from 1975 to obtain national vital statistics or subnational for the 21 countries from official sources. And this just shows the assessment globally by large clusters of countries, which we call super regions in the GBD lexicon, of the completeness of death registration. So high-income countries, we have complete death registration. And we have near complete in Central Europe, Eastern Europe, and Central Asia. For Latin America and the Caribbean, about 80% of deaths get registered. And then for the rest of the world, it's a much lower fraction, although there is marked progress in India and in China, bringing the South Asia and Southeast Asia numbers up. But for example, in sub-Saharan Africa, almost no progress in increasing death registration. Here's a visual on the completeness of death registration. So as mentioned, we are lucky that all the places in blue have essentially complete VR. And then all the places in other shades, we drop to much lower levels of vital statistics. Now, for GBD 2021, we've used the all-cause mortality and with a range of lags between very timely data releases for some countries, Norway is an example, to countries that tend to take quite a long time to release their all-cause mortality data. And we've had, as part of GBD 2021, to figure out excess mortality as best we could from during the pandemic. And this is deaths, excess deaths, not necessarily from COVID, but from the pandemic by country, but notably age standardized. And so you get a very different view of COVID once you age standardize, because age is the most important determinant of COVID mortality, and then obesity and diabetes number 2. But you get on the age standardized death rate very high rates in a number, or we think high rates in a number of low-income countries. The only countries in Africa with real data that go into this as opposed to modeled is South Africa, because the rest of the locations, there was a huge reduction in the amount of data being collected, whether from household surveys or from the demographic and health surveillance sites. Now, in the GBD, we have published recently the GBD 2021 results on causes of death, where we make use of the death certificates that countries collect. But notably, compared to what you may be used to seeing on mortality surveillance and cause of death, we spend a lot of time in the GBD trying to deal with the phenomenon that in different jurisdictions, more or less deaths get assigned to codes that really should not be an underlying cause of death or are ill-defined. And we use, for better or for worse, a term that some people really don't like, but we call those deaths that are assigned to those codes garbage codes, or deaths assigned to garbage codes. And we have quite an extensive set of algorithms to try to take those deaths and probabilistically reassign those to what might be more likely the underlying cause of death to enhance comparability. Now, as part of that exercise, we go through a process of looking at how much detail for the ICD each revision is reported, what fraction of deaths are assigned to these poorly defined or very aggregate or impossible causes of death, and then what fraction of deaths get registered. And we come up with a star rating of cause of death registration, where the 5-star rating, the vast majority of deaths are assigned to a legitimate cause of death, and they're captured by the system. And then you go down the different gradation. And in general, for a lot of the analyses in the GBD, we focus them on, in terms of model building, on 4- and 5-star cause of death data. But depending, we also have to make use of the 3-star data to build some of the models for low resource settings. Now, here's a type of analysis that we're able to do in the GBD by doing this. This is in the paper that was just published, where we're looking at the change in life expectancy from 1990 to 2021 and using the Dasgupta formula to decompose those changes into which causes contributed to the change of life expectancy. So if you're to the right of zero, those are reductions in those causes that contributed to increased life expectancy. And if you're to the left of zero, those are increases of certain causes. And most of that is green or yellow. Green is COVID. Yellow is other pandemic-related mortality. And then you can see, depending on the region, a smattering of HIV/AIDS, a smattering of diabetes and CKD that got worse. And in contrast, in South Asia, Sub-Saharan Africa, the biggest net contributor to improved life expectancy is that pale green color, which actually is diarrheal disease reductions. But you can see a broad array of causes contributed to enhanced life expectancy. And it's the sort of thing you can do when you have processed the cause of death data in a standardized way, including the sort of garbage code comparisons. Now, we have Canada in the GBD, and so here's just an example of after our processing of cause of death data, which deals with garbage codes, the rank order, and you can also get the numbers, of course, of causes of death in 1990 and in 2021, and you can see all the change with, dementia, chronic kidney disease, falls, Parkinson's, AFib, and drugs going up in the rankings, and then drops in some of the causes, most notably road injuries, stomach cancer, and aortic aneurysm really dropping quite considerably, but there's other drops in the Canadian data as well. Now, I was asked by someone to sort of illustrate this direction towards using our GBD algorithms and standard definitions on cause of death and all-cause mortality to drill down to subnational data. And a number of countries, 21 so far, ones that you'd be familiar with is like the US and the UK. France has recently joined this group, Norway, Sweden, other examples, Italy, Poland, and then a number of countries in other parts of the world, Brazil, Mexico, Colombia more recently, Ethiopia, Nigeria, and Africa, India, China are examples that are part of that group doing subnational burden. The most elaborate version of this is for the US, funded by the National Institutes of Health, their National Institute for NIMHD, National Institute for Disparities, and Minority Health and Disparities. And this is an effort to try to apply the burden of disease approach for 3,100 counties and to do it by race and ethnicity. And you get this sort of results, which turn out to be really quite useful, I think, and interesting. And we're just now starting over the last year or two to put out these results. And eventually we'll have the whole burden of disease machinery at this level of analysis. This is county life expectancy. Most of this exercise has to do with, at the life expectancy level, with dealing with small numbers. So these are, small area models that are being applied. And then we look by race ethnicity group. So American Indian, Alaska Native, Asian, Black, Latino, and white. And you can see very distinct patterns that emerge across different parts. And within a race ethnicity group, there is also quite marked variation that you see across these, with the dark reds here, by the way, as life expectancies as low as 60 and going up to life expectancies in the light green that are up in the 90s. So, and there's lots and lots of interesting local detail here that one can focus on. We have also done this for causes of death, and here's one way to look at that, which is to show the ratio of county mortality to national mortality. And that just helps you sort of identify hotspots for particular causes. For example, the second one in on the top left is HIV. And the vast majority of HIV is actually in Florida and Georgia and a few adjacent states, and it's particularly in Black populations. But we see for each cause a really quite unique pattern. Probably as you're familiar, Substance abuse in the second row towards the right is very prominent in the Navajo Nation and in New Mexico, Arizona, but also, of course, in West Virginia and Eastern Kentucky. You can see a sort of rural pattern out west for self-harm and interpersonal violence, as well as for transport injuries, and a number of cancer hotspots as other examples. If you're interested in those sort of, the potential of using mortality and cause of death data to do this very detailed place and race, ethnicity type analysis, all these results get put into an online tool called US Health Map as they get published. So we go through a process of peer review, and then as each of the tranche gets published, which has included all-cause mortality and cause of death so far, but eventually will include risk factor work as well as non-fatal work, it gets put into this US Health Map tool. Now, as an example of that risk factor work, which we are not yet published, but will be, we hope, in the near future, has been looking at one of the big drivers of why the US is so bad compared to other countries, which is obesity. And this is showing county-level obesity. In 2019, we, of course, have this back to, at least for this project, to 2000. It just shows you the extraordinary spatial and race ethnicity, and in this case, male-female differences in obesity. So the highest levels of obesity are in Black women, particularly in the Southeast. And then you have the lowest levels in Asian men, but really marked variation across the board in these groups, where for Black women, we have obesity in the 60% plus range. In fact, some counties are up to 70% are obese. And when we factor in overweight, we start to see 90% plus in some counties that are overweight or obese that have emerged. So, lots of potential here to then take this sort of risk exposure and link it to the mortality data, and which is what we're doing right now, to look at, for example, the spatial patterns and race ethnicity patterns in attributable deaths to diabetes, to obesity as an example. Let me end with this assessment from this work, where we've also been looking at relationships to educational attainment and using the education as recorded on the death certificate. There's lots and lots of detail that one could go into in that discussion. But what's really interesting here, and this is work that's led by Laura Lindgren-Dwyer at IHME and her team, as is all the other material I was just showing you, and Ali Magdad, another professor here. But this is looking at educational attainment on the death certificates. 2000 on the left, 2019 on the right. And looking at graduate degrees in the US in purple, college graduates, and red is some college, green is high school, blue is less than high school. And then showing the trends in life expectancy for those groups. And then to give context, relating that to the attainment of life expectancy for countries. And what you see is this story that if you're a college graduate in the US, you have some of the best life expectancy, equivalent to the best life expectancy at a country level. But for the other groups, you're doing very poorly. So a high school graduate alone looks like about a country ranked 79th. And if you are less than high school, you're towards the bottom of the countries in the world at 137th. But perhaps the most interesting insight is that in general, most countries of the world have seen progress in the last 2 decades, but not so in the US, except for those with a college degree or above. And then there's work underway to go the next level and try to intersect college with race ethnicity, education with race ethnicity, but that is work that is yet to be completed and has some technical challenges as well. So that's a flavor of how we're using mortality and cause of death data, perhaps to go a little bit farther through the GBD approach to come up with interesting, actionable, meaningful information that may help in targeting programs or identifying who's at greatest risk either now or into the future. So thank you.
Great. Thank you so much, Dr. Murray, for your presentation. And thank you, Derek and Emily, for your presentation as well. Two very different presentations covering some very important topics as relates to mortality data. So we're going to open up the floor to questions. Feel free to use the Q&A feature within Zoom. And we also received some questions prior to today's seminar that we will go through as well, and we will do our very best to kind of get through all of them. And again, feel free to ask your questions in the language of work for you, be it in English and or French. We'll start with the first question. The first question comes to us from an anonymous attendee, and that is, what is the difference between a coroner and medical examiner? Perhaps I'll pass that one over to Emily.
Thanks, Lewis. Yeah, so Canada has a mix of these types of offices, and really it's a lot of history involved. So the coroner's services started long ago in England. The whole philosophies behind them started off differently, but they end in the same place here in Canada in a death investigation system. Coroners can be medical. There can be physician coroners, as there are in Ontario, but there can also be lay coroners. So some coroners are not medically trained professionals. They can refer to forensic pathologists and others for medical services. And in the medical examiner service, which is where I'm sitting in Nova Scotia, is different in that all of the medical examiners are physicians with additional training, years of training in forensic pathology. So they're all board certified forensic pathologists and then medical examiners. So differences in the education and training and pathway. There are also lawyers who are coroners in Quebec. So it's differences across the country, and there's a lot of difference in the history of the systems.
Great. Thank you so much, Emily. And the next question I'm going to pose, maybe I'll open this up to either Dr. Christopher Murray and or Derek as well. So this question came to us from a registrant, and that is, what are the limitations or challenges of using vital statistics or death data within your respective pieces of work? So why don't we start with Dr. Murray?
Yeah, great question. This is sort of why we spend so much time trying to make sense of this garbage coding phenomenon, because if somebody assigns deaths to a very general category, let's say general atherosclerosis, it's not actionable from a public health point of view. You have to sort of try to figure out, is that ischemic heart disease? Is that something else? And the best way to address those is at the level when physicians are filling out the death certificate, of course. That would be ideal. And only a second best when you have to use statistical algorithms to sort of clean up the data afterwards. So there are all the limitations that go with who's filling out the death certificate, how much knowledge do they have about the death as they're filling it out. But having worked in many countries where they don't have vital statistics or civil registration and medical certification of causes of death, we shouldn't forget that it's an incredibly powerful tool to understand what's happening in a country. Because in the absence of that data, it's incredibly challenging to figure out what are the main health problems.
Great. And Derek, I'm wondering if you have anything to add to that.
Thanks, Lewis. I think the only thing I'll add is that what Vital Stats is lacking were the data through CCMed and right now directly from their offices is the circumstances around the death that go into much more detail, which is offers that information that is going to be useful to look at for discrete information in order to address the public health surveillance, and then to look at what those strategies could be to address those things. So those circumstance information really allows that public health action to take place.
Great, thank you. And Dr. Murray, this is going to go back to you, but can you please explain the process for a country like Canada to obtain subnational GBD data?
Yeah, what happens, I mean, we're right in fact, during like 5 minutes before the seminar, I just got a message about these sort of discussions with Santé Publique in France, where we've been mapping out how to get subnational burden with working together done for France. So in most cases, there are some active collaborators from a country who sort of trigger the discussion, and then this ends up being a discussion with either the national or the federal government or a contingent of state or provincial governments to map out what are the main data sources that should be included, how to go about respecting privacy rules and regulations, and what can be tabulated versus not, and sort of figuring out that data landscape, how much of the work can be strictly done, following the GBD protocols at a local level, because that makes everybody's life easier, and then feeding it into the general statistical machinery for the GBD exercise. So it's really just first sitting down and having that discussion about how we can get the job together, the job done. And we have lots of models, whether it's France, UK, New Zealand, or Italy, in high income settings to follow, versus how a range of what might work.
Great, thank you. I'm going to ask you one more question, and that's just around the level of data and the types of data that's collected or captured on US death certificates. So the question is, we're assuming that race and ethnicity data on death certificates supports the disaggregation as shown, and this is, I think, referring to the last slide, where you, I believe, showed a slide of education level.
Yeah, so we have quite a lot of, and Laura Dwyer is just an absolute, Lindgren Dwyer is extraordinarily skilled analyst and research team leader that knows chapter and verse. But different states have made modifications in the US to their death certificates at different points in time. So it's really quite messy. I'm showing the nice maps at the end of a very long analytic process to try to make sense of that mess. And you've probably seen in the media how the tick box for pregnancy was introduced in the US at different time periods, and that really has an effect on the maternal mortality trends. But likewise, we have on the death certificate educational attainment, and we have race ethnicity. Race ethnicity, the Office of Management and Budget in the US has changed the race ethnicity categories 3 times in the window that we look at the analysis. The 5 groups I was showing are there from the beginning. They introduced mixed race and some other categories, some time back, but that has not been as widely introduced across all states, or it's come in at different points. And then 2 weeks ago, we added a North African Middle East category, or OMB did. So that'll change the data prospectively in the future. Also on the thing I really want to emphasize, which I didn't mention because it wasn't really methods oriented, we have race ethnicity on the death certificate, and we have race ethnicity, which is filled out by the physician or the coroner or whatever who's filling out the death certificate. So it's a guess about race ethnicity. And then we have race ethnicity in the census or the American Community Survey, which is the actual personal assessment of race ethnicity. They don't match always. And so we have fortunate that the US Census Bureau and the National Center for Health Statistics has done some record linkage studies of taking race ethnicity as self-determined, and then looking on what's the death certificate. So we get some mismatch ratios from them. And we can even get that at a sort of subnational level. But that turns out for American, Indian, Alaska Native to be super important. because a lot of people, there's a real mismatch. So the death certificates are missing a lot of AIAN deaths, and we would get really strange results. Life expectancy is of 200 if you don't take that into account. So that's in the details, but it matters tremendously.
Great. Thank you so much, Dr. Murray. And we are almost at time. So thank you everyone for your questions. I know that there are still a couple of outstanding questions, and we will begin the process of identifying how best to kind of respond to those questions and share those answers with participants. So on that note, thank you again, Derek, Dr. Murray, and Emily for your time and participation. I'm going to pass it over to Signe to wrap things up.
All right, thank you to Derek, Emily, and Dr. Murray again for your insights and expertise. And thank you to all the attendees for joining us today. An evaluation survey for this seminar is available, and you can complete it either by scanning the QR code on this slide or using the survey link, which will be emailed to you shortly. And near the end of the survey, you will also be able to request a letter of participation. The recording for today's seminar and the presentation material will be available on NCCID's website in a few weeks. And that concludes today's seminar. Thank you all so much for joining us, and we will see you next time in our next seminar on Tuesday, May 28th.